Hello everyone, my name is Dagny Goodfellow and I will be doing my presentation on basal cell carcinoma. In my project, I intend to research the epidemiology, the background of this specific disease, the risk factors associated with it, such as genetic predisposition, and even the significance of UV exposure. After that, I plan to look more into the pathophysiology of this disease. In order to understand the clinical side of this disease, I was able to interview one of the providers at Cedar Dermatology here in Cedar City. Good morning, Jason. Can you tell me a little bit about what you do and where you work?
Sure, I'm a physician assistant here at Cedar Dermatology.
What would you say is the most common form of skin cancer?
Basal cell carcinoma is the most common form of skin cancer. It's also the most common cancer there is out there.
And then can you tell me a little bit what you look for when you're diagnosing this type of cancer?
Sure. Well, what I tell people, if you're a patient of mine and I'm looking for skin cancer, and I want you to specifically pick up on a basal cell carcinoma on your own at home, what I would tell you to look for is a pimple that isn't going away, or a sore that doesn't heal. Those are the most common things you'll notice that basal cell presents as.
And what are the different types and how do you treat each type?
Well, so actually, let's do this. Basal cell carcinoma is not all the same, so I like to do this little diagram for patients sometimes. So basal cell carcinoma is abbreviated BCC. You have a superficial or you can have invasive BCC. Okay, and not all invasive BCCs are the same. There's a few different flavors, or if you will, of basal cell carcinoma that's invasive. You may have a nodular basal cell, a sclerosing basal cell. So there's, not to get into some of the nitty gritty of it, but that's an invasive basal cell. On superficial basal cells, they're very thin, so we determine whether something's superficial or invasive on whether it invades the dermis. So if this is a skin diagram, here's the epidermis, right? And there's the dermis, and then this is all just subcu fat, okay? So basal cell carcinoma is up in here, and if that basal cell carcinoma is kind of like in this area, we call that superficial. Once the basal cell carcinoma gets down into here in the dermis, we call it invasive, okay? So superficial basal cells, very, very high up, very thin, not a whole lot there. And a lot of times we'll treat those with either a cream, or we can treat it with liquid nitrogen, or we can treat it with a tool called a curette. And that's how we treat superficial basal cells. I probably treat more superficial basal cells with a curette than I do anything else. Occasionally I will freeze them, it depends on the situation. And then rarely we can use a cream, but more for people who were trying to limit scar tremendously or aren't great surgical candidates or something, can't handle it. It's not quite as definitive. Invasive basal cell carcinoma, you basically have two options, and they're both surgical options. You can do an excision, or you can do something we call a Mohs procedure. And what that does is if I have invasive basal cell in here, right, that, rather than just taking the top little piece off, is actually going to come in and cut this out into the subcu tissue, and it's going to take that whole block out. And an excision would be this kind of thing. If this is my basal cell carcinoma, then we have a certain distance around the thing that we want to clear, and we actually cut that out in a football or an ellipse, we call it, shape. Okay, so we make this incision, and then we kind of take the whole thing out, if you will, in that fashion. And usually there's some subcu tissue down on the bottom, just fatty tissue here. And then you have the dermis. We're trying to clear that out into that tissue. We take that out, and now we have a defect that looks like this on the person. And here's kind of muscle or subcu fat, and then we'll just stitch this up. And they come out with a line scar. And then they're done. And usually that's the end of it. We have them come back in a few months and follow up, and we just kind of keep an eye on things. Most procedures are a little bit different. If this is the tumor, we may be trying to spare tissue. So let's say if we're working on somebody's eyelid or a nose or an ear, somewhere that we don't have a lot of real estate, on the shoulder, the back, the leg, something like that, we have real estate that we can take a chunk out and we can take some margins. But in those skin sensitive areas, if you will, we don't have a lot of real estate. We want to cut close to that tumor and not take a lot of extra out. So we do what's called a Mohs procedure, where we take that piece out and we check it on a machine while the patient sits here in the office. And if that's clear and we get the whole tumor out, then we just figure out what's the best way to sew that up, and we go back to this sew it up stage. If it's not clear, we have it oriented in such a way that we can tell where 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock are at on the specimen we took out, which means it's the same on the person we took it from. And we can look at that under a microscope and say, hey, there's still tumor here at 6 o'clock. Okay, well then now we come back to the defect on the person and we say, let's just take out this little half moon at 6 o'clock on the defect, and let's send that piece off to be checked. So we would expect to have tumor in here, and we want to see if that tumor comes all the way to the edge. And if it does, well, we come back and we take another piece and we take another piece until we have the entire thing out. Kind of like peeling an onion from the inside out. Once it's clear, then we go back in the room and we stitch it up, and the same follow-up. 3 months, we have them come back in, we check it, do a good look over, we look them all over. And one of the things I tell patients is the reason we want to see in 3 months is twofold. One, we want to see that the surgery site has healed well and doesn't have any more tumor clinically appearing there. And then the other thing is that when, I use the analogy of popcorn. When a popcorn kernel pops in the microwave, you kind of know there's another one going to pop soon. And when somebody's had a tumor, you want to make sure that their timer hasn't gone off and they're going to get more of them. So I've had a number of cases, countless, that you have somebody come in and their 3-month follow-up gives you another skin cancer on their cheek somewhere or some other place. So we have them come back and then we check them periodically based on what they've had and what's going on for additional skin cancers. But
Perfect.
Does that answer the question?
That's perfect. Thank you so much, Jason.
No, you're very welcome.
After listening to the physician assistant Jason, I will be able to use his anecdotal evidence in understanding the clinical side of this disease, and I hope to learn even more about the effects and the discovery of this disease through other research.